welcome to this week's episode. If you're just joining me, I'm Dr. Susan. I'm a board-certified gynecologist, 100% dedicated to taking care of women in midlife, women just like me in perimenopause, menopause, and beyond. And I'm often asked, what labs should I ask my doctor to do? Because let's face it, most doctors are not going to look that critically into your lab work because, frankly, they don't have time, and that's just a sad state of affairs. So we may have to take accountability for ourselves and ask for the labs that we need. So what I'm going to do today is actually go through a set of labs from a real live patient, actually someone I saw today, and I'll show you the numbers, anonymously of course, that we got, and I'll tell you exactly what I told her. So this will be kind of like a mini version of a consult that you might have in my office if you were to come to me as a patient. Now I will tell you that consult would normally take 60 to 90 minutes, so I'm going to shorten it a little bit because I know no one wants to watch a 90-minute YouTube video. But let's just go through these labs, and there'll be a list at the end so that you could literally ask your doctor to draw these labs, or you could go to a place like Any Lab Now and just order them yourself. So let's just start from the top. I'm going to read through these, and then I'll show you some screenshots as I go. So what we do with our new patients is we ask everybody to come in fasting, and that is with 8 hours of not having anything to eat or drink. Tea, coffee, or water is fine. The reason for that is that some labs are affected by food, like obviously sugar, cholesterol, etc. So the standard is to do labs in a fasting state. So that being said, this particular set of labs is from a postmenopausal woman. So just as a review, when we're postmenopausal, what would we expect? Remember, estradiol, the primary estrogen that we make in our ovaries, progesterone, and testosterone would be expected to be pretty close to zero. Now, if I were drawing labs from someone who was still having periods, that would mean perimenopausal, it would be critical for me to know what day of the month those labs were drawn. So if you're still having periods and you get this lab work done, the best time to do it is during your period. We usually say day 3 to 5, with day 1 being the first day of your period, or if your periods are regular enough to know when this might be, a week before your next period. So, for example, if your cycles are 28 days apart from the start to the start, a week before would be approximately day 21, or 3 weeks after your period started. Make sense? So, early in the cycle, or a week before your next period is the best time to do blood work, and I'll tell you why shortly. However, if you're not having a period, if you're menopausal like this patient, we would expect all of those hormones are zero. Make sense? So this particular video is specifically about lab work for a menopausal woman. That's someone who has not had a period for some months. This particular patient hasn't had a period for 3 years. So before I even look at the labs, I already know her estradiol, progesterone, and testosterone are going to be pretty close to zero. At the end of this, I'm going to talk a little bit more about perimenopause. So if you're in that group, just hang tight. We'll get there. Okay, so in no particular order, this is just the order that the lab prints it. First page, we're looking at, I'm going to go down to the bottom, a lipid panel. Now, basic lipid panel, and I've talked about this recently, is basic. That means it's not comprehensive. It's just a high-level look at what your lipid panel is with the goal of determining whether you're at higher risk of heart disease. So this particular patient, as you can see, has a cholesterol of 176 total cholesterol. I don't look at that number too much, but that is certainly in normal range. HDL of 64 is great. We want it to be something greater than 50. Now, if you look over to the right and look at these reference ranges, I'm going to tell you multiple times that I'm not going to be agreeing that that's an optimal number. But in this particular case, yes, HDL greater than 50, that sounds good to me. Forget the cholesterol HDL ratio, that is not useful. Triglycerides less than 100, that's very good. So this patient has an excellent lipid profile so far. Low density lipoprotein, we want to be less than 100. So I can look at this and say this is pretty perfect. Another thing we want to look at is the triglyceride to HDL ratio. So in this patient, 74 to 64. That is an excellent ratio. We want it to be less than 2. In this patient, it's approximately 0.8. So 2 is good, less than 1.5 is rock star. So this is a patient who's not on any lipid-lowering medications. She's 58 years old. I'll just tell you, she lost 200 pounds. Did not look like this before, just as an example of how weight loss can completely fix your labs as well as lowering your cardiovascular disease risk, so go her. Now, let's pop up to the top. You'll see this number for ApoB that I talk about all the time. If you look back at the video I made about cholesterol a little while ago, talked a lot about these things. So ApoB, as a reminder, is a protein that's on the outside of these little packages of cholesterol. I think about them like little soap bubbles. And in order to float in water, they have to have protein around the outside. Otherwise, fat can't float in water, right? So ApoB is cool because it picks up not only low-density lipoprotein, or LDL, which we used to call bad cholesterol, but we don't have to call it that anymore. It's just doing its job. Not only LDL, but all the other alphabet soup. Low-density lipoprotein, that's LDL. Very low-density, intermediate density, lipo little a. What they all have in common is they have an ApoB protein on the outside. So ApoB of 79 is a pretty good number. We want it to be less than 80, so that is a very good number. Hey, even lower would be fine, as low as possible. If you look at that reference range, we do not want to be at the top. So remember, reference ranges are not optimal ranges. They're simply saying this is what people have. That particular one, you want to be at the lower end. So 80's fine, 60's better. Over 80, I would say, is too high. So great ApoB, great lipid panel. Now, because of that, we're not going to dig any further. But if those were not looking so pretty, we would dig further and do some more lab work to dig into it more. Again, this is just a very high-level, basic look, but this patient passed it with flying stars. Now, jumping down to homocysteine. That is a nasty inflammatory marker. We want it to be low, again, as low as possible. Less than 9, less than 10. The lab says less than 15. That's way too high. There actually are some very good studies showing that homocysteine, even over 11, is associated with a very large increased risk of Alzheimer's disease, for example. So homocysteine is a very long story that we'll talk about in another podcast, but it can be a marker of inflammation that can affect our blood vessels, and that's a very long story, very short. But if it's 8 or 9, that's fantastic. If it were 10 or higher, we would treat it, and we would treat it by taking B vitamins. So really simple. If your homocysteine's high, we give you a combination of B vitamins, including methylfolate, which is the active form of folic acid, B6 and B2. I like the product called MethylGuard. I take one of those every day. Basically, that is supplying a methyl group to complete this process called methylation. Too much to talk about today, except to say we want to have good methylation. That's what keeps our DNA healthy. Very, very long story, very short. Anyway, homocysteine's normal. If it's high, we want to fix that.